evening, everyone. Miss Clarence, can you mute your mic? Thank you so much. So, good evening, everyone. Hello, hello, hello. How is everyone? Kamusta kayong lahat? So, I can see from the group chat, sabi, excited daw sila sa sexual assault. Yes, dear, I can hear you. Hello, hello, hello. Good evening. Hi. So just a kind request, kindly mute your mics. Maraming salamat sa inyong lahat. That's a pleasure. So, I'd like to introduce you to the team who will be handling you today. Hi there at Malawi. So I am your mentor, Melissa, or mentor Missy. I'll be your mentor for today's session. And today we are tackling disseminated intravascular coagulation versus HELP syndrome, hemolysis, elevated liver enzymes, and low platelets. Okay, so just a reminder, please, my dear beloved colleagues, it would be best for everyone that you kindly mute your microphones. Why? So as not to disturb your classmates during this very, very short study session of ours. Just like what we're saying, this is a study session, so it is best that we are. Our facilities are all here and we're able to concentrate. Okay? So, maraming salamat. Thank you very much to everyone. And let us begin, Sir Chris. So it has been said that disseminated intravascular coagulation is a long-standing topic in the NCLEX, the NGN now. Now, okay, here we go. So please kindly give me. Okay. Okay, let's go for the vanishing pen. So let us look into what are the definitive topics that we have, or what are the definitive concepts that we have to memorize with regards to this very complex, these two conditions, and how we will be able to marry it. So, USRNs to be, are you ready? Because I am. Now, let us be inspired. So this is one of our recent passers amongst the hundreds, the thousands of passers. I myself, I am a Gapus baby since 2005. I was with Sir Ray when I graduated 2005. I passed on my first take. I took my CGFNS for the certification, also under Gapus, and I also took my NCLEX the following year under Gapus, and I passed. So let us talk about disseminated intravascular coagulation versus HELP syndrome. I remember during one of our study sessions, I discussed HELP syndrome. Now what we're going to do is we're going to marry both topics. So let's focus on DIC initially. So, to make this short and sweet, when we talk about disseminated intravascular coagulation, what is it in the big paradoxical condition? What is the big picture? So, what's happening here is the body clots and bleeds at the same time. Okay, so what happens here is that the body, something triggers massive widespread bleeding all throughout the body. Okay, really massive bleeding throughout the body. And because of that, we have our clotting factors, right, that aid in the bleeding. So, but since the bleeding is massive, the clotting factors get all used up. Okay, now since it gets all used up, now the patient cannot clot when they actually need to, and there will be bleeding that would occur all the time. Okay, so that is DIC in a nutshell. Now, what causes it? So remember the triggers. Stop making clots. So one of the most common triggers, you have your sepsis, you have trauma, you have your transfusion reactions, you have some of your obstetric emergencies. And what are those? Abruptio placenta. So what is abruptio placenta? It is the premature separation of the placenta from the uterine segment. Okay, you have your amniotic fluid embolism, and you also have your eclampsia. Now, eclampsia is simply your higher form of preeclampsia, wherein the patient who has hypertension and proteinuria already displays seizure activity. Okay, and DIC can also be caused by pancreatitis or cancer. Okay. So some tips for you. Now, if a question gives you a postpartum patient who is bleeding from her IV site, okay, you would want to think DIC, okay? D-dimer. This is the most sensitive lab indicator for disseminated intravascular coagulation. Now, since we are saying that the patient is bleeding massively, of course, there needs to be blood replacement. So what replaces it? So you have your fresh flows in plasma, which is replaced by your clotting factor, which replaces your clotting factors. And you also have your cryoprecipitate, which replaces your fibrinogen. Okay. Now, when you are asked for a question with regards to treatment, it is normally you want to treat the cause first. Now, what is the cause? The cause of the bleeding, the cause which ended up the patient with disseminated intravascular coagulation. So remember that DIC is never the primary disease. It's always due to something else. Okay, wait, let me. So remember that DIC is never the primary disease. It's always due to something else. It won't. Oopsie. Hold on, please. Okay, so going back, not HELLP syndrome. Mhm. Oopsie. Okay, hold on, please. Okay, so going back, not HELLP syndrome. Okay, okay. So moving forward, how again does one get DIC? So it can be through sepsis, it can be through trauma or an obstetric emergency. And this will cause your massive clotting, wherein there will be the activation of your clotting cascade system. And this will result to your massive microthrombi. And if there is a lot of these little thrombi, this will cause your organ damage. And aside from your organ damage, this will also cause your clotting factors to run out, which is the second phase of disseminated intravascular coagulation. And at the end of the day, since you do not have enough clotting factors anymore, this will lead to your uncontrolled bleeding. Okay. Now, that is a brief overview of your disseminated intravascular coagulation. Any questions so far before I proceed to your HELP syndrome? We're good? Okay, so let us proceed to HELP syndrome. And we have these markings again. So HELP syndrome so far before I proceed to your HELP syndrome? We're good? Okay. So let us proceed to HELP syndrome. And we have these markings again. So let me give you some tips. Remember the acronym. You have hemolysis, elevated liver enzymes, and your low platelets. That's what HELP syndrome stands for. And your delivery is always same with your disseminated intravascular coagulation. This is the definitive treatment. Now, when you administer magnesium sulfate, they say, no, actually, not just they say, this is for seizure prophylaxis, meaning this is not to lower the patient's blood pressure. This is to prevent your seizure activity for your clients. And another thing is, know your antidote, which is calcium gluconate. Now, mag sulfate is given for seizure prophylaxis. Remember that it does not treat HELP syndrome. And therapeutic range of magnesium sulfate would fall between 4 to 8 milligrams per deciliter. Now, you want to look for signs of toxicity when you administer magnesium sulfate. Loss of deep tendon reflexes, respiratory depression, less than 12, and decreased urine output. So you remember your code URP. Okay, that's urine output, respiratory rate, and your patellar reflex. Okay, also take note of your okay. Also take note of your right upper quadrant pain. This is one of your hallmark symptoms or syndromes. So why? When you talk about right upper quadrant or epigastric pain, this is the classic symptoms that should always raise a suspicion for HELP syndrome progressing, especially in a pregnant patient in the third trimester. This isn't just heartburn or a normal pregnancy discomfort. Okay. Now, another thing is postpartum monitoring is critical, and the condition often worsens before it actually improves. And you also have to watch for your platelet count. This indicates the severity of HELP syndrome, and it will guide you in the management of your patient. And always, when you are to answer a question with regards to HELP syndrome, prioritize maternal safety. This indicates the severity of HELP syndrome, and it will guide you in the management of your patient. And always, when you are to answer a question with regards to HELP so syndrome, talking about HELP syndrome again, so for HELP syndrome, this is one of the most severe variants of your okay. So talking about HELP syndrome preeclampsia. So hemolysis, elevated liver enzymes, low platelets. Okay, and this usually occurs in the third trimester. So when you see or answer choices, just like what I said, you would like to prioritize your maternal safety first. And also, you would want to check for your good fetal outcomes because with HELP syndrome, the mother's life is in immediate danger, and without a healthy mother, the fetus has no chance of surviving. And also, you would want to check for your good fetal outcomes because with HELP syndrome, looking into this, how does HELP syndrome progress? You have first your placental dysfunction. So it could be due to abruptio placenta also. It could be due to your preeclampsia, okay, which causes the lack of oxygenation to the placenta, and this causes your systemic endothelial damage, and there will be your vessel narrowing, and that will lead to your increased LDH, increased bilirubin, which is your hemolysis, your increased AST, increased ALT, which will lead to liver necrosis, which is your elevated liver enzymes, and your low platelets, which is your less than 100,000 platelet consumption. And that is your HELP syndrome. So what are you to do? Deliver the baby immediately via cesarean section. Then you would want to provide if the mother is left untreated, this can cause your DIC, this can cause liver rupture, it can also cause renal failure and your stroke. Then you would want to provide if the mother is
Now,
left
let
untreated,
us
this can
correlate
cause your DIC,
DIC
this can cause
versus
liver
HELP
rupture, it can
syndrome.
also cause renal failure
Okay,
and your
so when we
stroke.
say disseminated intravascular coagulation, what's happening here again? I repeat, the clotting system goes haywire. There are clots everywhere, and this uses up all the clotting factors, and this leaves the patient unable to stop bleeding. So, just like what I place here, think clot everything and bleed everywhere. So, and these are your key triggers. It can be OB related, it can be fluid embolism, it can be sepsis, it can be due to a retained fetus. Now, what are you going to see? So, you are going to see, of course, bleeding. So, where will you see your bleeding? So, it can be from the IV sites, from the gums, you will be finding your petechiae. So you will be noticing decreased platelets, decrease of fibrinogen, an increase in your PT, an increase in your D dimer. This is classic. And you will also notice your positive fibrin degradation products, your FDPs. So, how are we to treat our patients undergoing disseminated intravascular coagulation? You will treat the cause, of course. So if the mother is undergoing abruptio placenta, then you may have to deliver the baby immediately. If it is cancer, you will have to deal with that. Aside from that, you will have to replace the blood products, which could be replaced with your fresh frozen plasma or your cryo precipitates. Please give me a few seconds. So let me give you some mnemonics that can help us all. So disseminated intravascular coagulation, think death is clotting. Oopsie, hold on, please. Mhm. Okay. So I think this is given in your handouts also. So think DIC, death is clotting. So this will lead mother to bleed out everywhere. Okay, help. Her liver is in pain. Think preeclampsia and right upper quadrant pain. Now, if the question mentions a D dimer, immediately D, think DIC. Now, if the question mentions preeclampsia, and right upper quadrant pain, think HELP syndrome. Okay, this is usually how it goes about. Okay, in a simple sense, because we always want it to be simpler for you. Mhm. Okay. Okay, so let us have, since we are talking about
you know, HELLP syndrome versus disseminated intravascular coagulation. So let's talk about the difference between the manifestations. So first, you have for DIC, you have your coagulation, and then for HELLP syndrome, this is one of the most severe preeclampsia variants. Now, what is the main problem with our patients undergoing these markings? Hold on, please. So, what is the problem with our clients undergoing your disseminated intravascular coagulation? Why is it going back, sir? Okay. So you have clotting, then please give me a few seconds. So you have your clotting and then your bleeding. Now for HELLP syndrome, you will notice your liver damage and your platelet destruction. Now, how about the PT and PTT? You will notice that in disseminated intravascular coagulation, there will be an increase in both your PT and PTT. But if you compare it to your HELLP syndrome, it is usually normal. Now, the D dimer, this is a hallmark sign of your DIC. So always think at least D, you have disseminated intravascular coagulation. Clear all drawings. Okay. Now, how about for your liver function tests like your AST, ALT, LDH, bilirubin? You will notice that in disseminated intravascular coagulation, it is mildly elevated, but for HELLP syndrome, it is significantly elevated. Now, how about right upper quadrant pain? You will hardly observe this in disseminated intravascular coagulation, but you will be observing this in your HELLP syndrome. So how about blood products? So treatment would be for DIC, you would give your fresh frozen plasma, your cryoprecipitate. Now for HELLP syndrome, you will have to deliver that baby immediately. So let us move forward to one case that we have created for today for you. So here we have Maria comes in complaining of severe headache. She is complaining. So this is a case study. She's Maria, 28 years old, G2P1, 34 weeks AOG. So she arrives at the emergency department. So she comes in complaining of severe headache, blurring of vision, right upper quadrant pain since this morning. Her husband says she's been not feeling well for 2 days. Now, these are her vitals. You get a blood pressure of 158 over 104, heart rate of 96, respiratory rate of 18, a temperature of 37.1, and your urine output, which is decreased, wherein the urine appears dark. So, this patient also appears you have your hypertension, you have your headache, you have visual changes. She has right upper quadrant pain, edema in a pregnant woman. So, think again, what will you think? HELLP or disseminated intravascular coagulation? Actually, the answer is here. You will think HELLP syndrome first. So do you agree with me? Is this a case of HELLP syndrome or is this a case of DIC? Let me know. DIC or HELP, dear colleagues? Yes, very good. So this is still a case of, correct, your HELP syndrome. Now, since we are in the HELP phase, let us look. Okay, what are your labs? Look at the platelets. There is a decrease in the platelets. Okay, look at your AST and ALT. Okay, AST 220, ALT 198. Your LDH is at 890. Your bilirubin is at 2.8. Your PT and PTT, they're normal considerably. Your D dimer is normal. What did we say? DIC, D dimer. And your fibrinogen is
normal. Okay, so look down under, I placed a little note here for you. So here, HELP syndrome is now confirmed. So hemolysis, you have an increase in your LDH, an increase in your bilirubin. You also have your elevated liver enzymes and your low platelets. You have it all. It's definitely HELP syndrome. Let's move forward. Now, what are you to do during the HELP phase for Maria? Of course, you will have to notify your doctor immediately. Notify the OB stat. Now, you will have to prepare to administer magnesium sulfate for what? Seizure prophylaxis. Ideally, that's 4 to 8 milligrams per deciliter. Now, again, what are you to watch out for when you administer Magsul? What are you to determine? You want to watch out for the patients? The code is there. I typed it. URP. Very good. Urine output, respiratory rate, and your patellar reflexes. Good job, colleagues. Now, of course, I just said a while ago that magnesium sulfate will not lower the blood pressure. Now, since this is a severe case of preeclampsia, you have that problem with your increase in the blood pressure. So, you will still have to give your antihypertensives. And what are those? That's your labetalol, hydralazine. Could be that. Very important. Monitor that baby. Okay. And you will want to prepare for your emergency delivery. I'm sorry, this keeps on coming up. Okay. Prepare for your emergency delivery and monitor for the DTRs and watch out for your magnesium toxicity. Now, what is the antidote for magnesium sulfate? Your calcium gluconate. Very good. And then strict INO monitoring, my dear ones. Okay. Now, let us move forward. Are we good here? We good so far with Maria? Okay. So, let's move forward.
Mhm. Hi. Why is it not moving, sir?
We good so far with Maria? Okay. So, let's move forward.
Mhm. Sir? Hi. Why is it not moving, sir? Mhm, mhm. Okay. Anyway, I need help with the slides, please.
Sir?
Mhm. Please give us a few seconds. We're undergoing um a slight um technical challenge. Okay, so I will display my slides. I will be the one. Hold on. Hold on. Let me just share. So, dear colleagues, I am displaying my slides. Let me know if you are able to view. Are you able to see? Okay, because I do not want us to be delayed. So, moving forward, okay, so here we are at HELP syndrome. Okay, right. Now, this is what we did during the HELP syndrome phase. Now, the issue progressed. Okay, the issue progressed. So 3 hours later, the condition worsened. So this is like, what do you call this? A TV series. If they still do this. So, okay. So 3 hours later, the condition worsens, and then Maria all of a sudden develops. So there is bleeding from her IV site that won't stop.
Okay, there is petechiae and bruising spreading across her arms. You now have vaginal bleeding, it's increasing. My goodness. And then, if a while ago the blood pressure was extremely high, now the blood pressure is already at 88 over 60, and the patient is currently in shock. And you have your urine output drops to 30 ml per hour. Now, when you check for the status of the baby, the fetal heart tones are showing late decelerations. And what is an indication of your late decelerations for our babies? This is a clear indication of placental insufficiency. Okay, so now Houston, we have a problem. Okay, so let us proceed. And so the doctors ordered repeat laboratory labs. Okay, now looking at the platelets, there is now a decrease in the platelets. You're at 30,000. And when you check for the PT, there is an increase to 22 seconds. And your PTT, there is also an increase to 68 seconds. How about your fibrinogen? This is your normal, okay, to compare. So your fibrinogen, there is now a decrease, hypofibrinogenemia this time. And your D dimer, now you have a D dimer, is it's at 4.5. And when you check for your FDP, it is now positive. And your AST and ALT are still currently elevated. Now, look at here. I have a little note for us all. HELP has triggered your DIC. Okay? Because of the massive bleeding, clotting factors are now consumed. You have a depletion of your fibrinogen, you have your D dimer and your FDP, and there is bleeding everywhere. We will now conclude that from HELP, the patient, Maria, is now undergoing after 3 hours. What is the condition? Disseminated intravascular coagulation. Are you able to follow, colleagues? Okay, perfect. So, at this time, what must we do? So we don't just call our doctor, we call for an OB code already. We need a rapid response team in. Prepare for an emergency cesarean section. Now you will prepare for the infusion of your fresh frozen plasma, your replacement of your fibrinogen, which is your cryoprecipitate. You also have to replace your platelets and your pack RBCs. All of these have to have to need to be administered. Now, these are some key points that I would like Mhm. before we end. These are some key points that I would like to address to you. Remember, always help can, okay? It doesn't always happen. That's why it's essential that you are able to arrest actually, not just help, you're able to arrest preeclampsia because preeclampsia can progress. Remember, help is a severe form of your preeclampsia. So, at preeclamptic stage, you don't want the patient to undergo eclampsia. You also don't want it to progress to HELP syndrome. Because remember, HELP can lead to disseminated intravascular coagulation. So if there is uncontrolled HELP syndrome, this will deplete your platelets and this will lead to your clotting cascade and there will be a depletion of your clotting factors and this will lead to disseminated intravascular coagulation which will cause your massive bleeding. Now, watch for the turning point. What is the turning point? You're bleeding at IV sites, you're dropping of your blood pressure, which is an indication of your shock. So this is a red flag. Actually, your alarm bell that says disseminated intravascular coagulation is already happening. Now, you will have to deliver the baby. So again, Just a reminder, magnesium sulfate is not a blood pressure drug. D-dimer and FDP positive, this will confirm disseminated intravascular coagulation. This is not an indication of your HELP syndrome. And your priority nursing action is provide safety for mommy. You need to notify your provider, you need to call for an OB code, and you need to prepare the delivery room for an emergency cesarean delivery. Are we clear so far? So we've made it very, very simple for you, and we have married the two concepts for you to easy to for it to be easier. Okay, it is never an easy concept. That's why we're all here, but to make it more fun and also easier for you. Now, let us move forward to some sample questions. Okay, so question number one. So you have Anna, she's 38, G1P0, 36-weeker, admitted with a blood pressure of 160 over 105. So she's manifesting with a severe headache, right upper quadrant pain. Look, right upper quadrant pain. So your lab show your platelets of 80,000, AST of 210, LDH of 920. Which condition does the nurse suspect? Actually, even without the choices, I think you will be able to answer this. Very good. Let's see if we are correct. Very good. That would be your HELP syndrome. You have your classic triad. What is your classic triad? You have your hemolysis, your elevated LDH, you have your elevated liver enzymes, and you also have your low platelets. Okay, for your also you have your right upper quadrant pain and hypertension. So again, one trick that I am teaching you, think right upper quadrant pain, low platelets, high liver. Actually, the term itself, hemolysis, elevated liver enzymes, low platelets, will make you answer the question. Now let's go to another question. You have a postpartum patient who was diagnosed with HELP syndrome, suddenly develops oozing from her IV site, petechiae on her arms, vaginal bleeding. Her repeat labs show a PT of 24 seconds, PTT of 70 seconds, fibrinogen of 85, and a positive D-dimer. What is the priority nursing action? Is it apply pressure dressings to all bleeding sites? Is it administer magnesium sulfate as ordered? Is it notify the physician stat and prepare to administer your blood products? Or is it encourage oral fluids to increase circulating blood volume? I see. Wow, my goodness. I love it. And you are correct. So you want to notify your physician stat and prepare your blood products. This is already, okay, an indication of disseminated intravascular coagulation. And what do you have here that is an indication? You have your elevated PT, check. You have bleeding from multiple sites, check. You have your D, positive D dimer, check. Low fibrinogen levels, check. Okay, and the priority is you want to notify the doctor right away, replace all those blood products which are being lost as of the moment. Okay, so if we go back, okay, so A, wrong. The pressure alone won't fix it. Okay, this is not a systemic clotting disorder. So A, wrong. No. How about B? Okay, magnesium sulfate is again for seizure prevention. This is not for disseminated intravascular coagulation management. Mali, again, wrong. And then D, wrong. Encourage oral fluids to increase circulating blood volume. So oral fluids inadequate and inappropriate in a client undergoing active hemorrhage. Okay? Coagulation management, mali again, wrong. And then D, wrong. Encourage oral fluids to
So,
increase your
another memory
platelet
trick for
volume.
you.
So,
So, take
oral
note of
fluids
bleeding
is
from your
adequate when they
unexpected
have
sites
outbreak
and
in
your
a
abnormal
diet
PT
undergoing
and
active
PTT, your
depletion.
positive D
Okay?
dimer, DIC, and give your blood product stat. And to close off our session,
So, another memory trick
oh,
for you.
we
So,
only have
take
two
note of bleeding
questions.
from your
So
unexpected
there we
sites
go.
and your
That
abnormal
is our
PT and
short
PTT,
discussion.
your positive D
Ma'am, is the
dimer,
study group
DIC,
done daily?
and
May I
give
please
your
be
blood
added to the
product
group?
stat.
This is
And to
actually, I
close off
think,
our session,
we have
oh, we only
the
have two
schedule
questions. So,
currently, and it
there we
is
go.
not
That
done
is our
daily. I
short
think this is
discussion.
done
Ma'am,
weekly.
is the study group done
Yeah.
daily? May I
So
please
right
be
now for
added to the group?
April, there
This is
is
actually,
on our
I
group
think,
chat, there you go.
we have
By Evelyn.
the
So it is
schedule
every Monday,
currently,
6 to
and
7
it is
p.m.
not
Manila
done
time, okay? Think
daily. I
Manila
think
time.
this is done
So there
weekly.
are different topics that will be
So right
discussed.
now for
So I
April,
think,
there
let me
is on our
check.
group chat, there you
For the
go,
next
by
topics, you
Evelyn.
have, there
So
are
it is
various
every
topics
Monday,
which will
6
be
to 7
discussed. We
p.m.
have
Manila time, okay?
sexual
Think
assault by
Manila
Miss
time. So
McLean.
there
We
are different
have,
topics that
wait,
will be
let me
discussed.
check.
So I think, let me check.
Let me
For the
check.
next topics, you have, there are various topics which will be discussed. We have
Uh-huh.
sexual
Hold on.
assault by Miss
Oh,
McLean.
okay. So
We
these
have,
are the topics. On
wait,
April
let me
13,
see.
you have hypokalemia versus
Let me check.
hypocalcemia. That's by Mentor Angela. And then on April
Uh-huh.
20, there is
Oh,
idiopathic
okay. So these are
thrombocytopenic
the topics. On
purpura
April
that is
13,
by
you have
Mentor Abby.
hypokalemia
And
versus
then on April
hypocalcemia.
27,
That's
we
by
have
Mentor
sexual assault
Angela.
by Mentor
And
McLean.
then on
So those are topics
April
that you can look
20,
forward to, and these
there
are
is
trending in the
idiopathic
NGN right now. I
thrombocytopenic
think I might also sit
purpura that
in
is
so
by
that I can add
Mentor
on
Abby.
to my
And
knowledge, and it's
then
very
on April
interesting. So maybe I'll be
27,
seeing
you
you there.
have sexual assault
Okay.
by Mentor
Any
McLean.
questions so
So
far?
those are topics that you
It
can look
has been a
forward to, and these
pleasure
are
being with you
trending in the
today.
NGN right
Maraming
now.
salamat sa
And
inyong
again, I want to sit in
lahat. Did you
so that I can add
learn?
on to my knowledge, and it's very interesting. So maybe I'll
Thank
be
you,
seeing you
thank you,
there.
thank you.
Okay?
Thank you, my dear
Any questions so
nurses.
far?
Hope to
It
see
has
you
been a
again.
pleasure
Please
being
don't
with you
forget to
today.
attend the next
Maraming
sessions.
salamat sa inyong
Don't
lahat. Did
forget to
you
attend.
learn?
And it's a pleasure being with you all. I hope
Thank you,
to.
thank you, thank
Is it for us?
you.
Yes,
Thank you,
it's
my
all
dear
for you.
nurses.
Sir Ray created this
Hope to see
for
you
all the
again. Please
nurses
don't
who
forget
would
to
want
attend
to
the next
join and who
sessions.
would want to learn.
Don't
So
forget to
just
attend.
come
And
and
it's a
attend
pleasure
every
being
time
with
there's a
you
session.
all.
And
I
it
hope
also
to
encourages
keep
us
it for us.
to,
Yes,
you
it's
know,
all for
reconnect with all
you.
of you.
Sir Ray
Yes.
created this
Please
for
attend. Please
all the
attend. So that's
nurses
every
who would
Monday,
want to
6 to
join and
7
who would want
p.m.
to learn.
Manila time.
So
And we're
just
looking
come
forward to
and
having
attend
all of
every
you
time
here.
there's a session.
It's
It
more
really
fun if you're all
encourages
here.
us
Okay?
to, you know, keep moving
Okay, it's been a
forward.
pleasure to be with
Yes.
you all.
And
Maraming salamat.
every
That's thank you
Monday,
in
6 to
Filipino. And
7
hope to see
p.m.
you again.
Manila time.
God bless you
And we're
all.
looking
If it
forward
is
to having
evening in
all
your
of you
country,
here.
have a good evening.
It's more
If it
fun
is
if
the
you're all
morning in
here.
your country,
Okay?
have a lovely morning.
Okay, it's been a
And
pleasure to be
God
with you
bless.
all. Maraming
Bye.
salamat. That's thank
Thank
you in
you.
Filipino.